Good morning, everybody. If you will, come on in and let's have a seat and get started. Representative Hawkins, would you come join us? Thank all of you for getting up early this morning and coming. We're going to go ahead and get started. And first on our program is the agenda, Georgia Composite Medical Board, Robert Jeffrey, Executive Director, Interim.
Morning, Mr. Chairman and members of the committee. I'm Bob Jeffrey. I'm the Interim Executive Director for the Georgia Composite Medical Board. And I'm Bob Jeffrey, and I'm Interim Executive Director for the Georgia Composite Medical Board. And at this point, I'm about halfway done because we have no recommended changes in our fiscal year 16 budget. We can provide an update. You've got some information in front of you where we tell you about the implementation of House Bill 504, which was the Vaccine Protocol Registration or Agreement Act. It required pharmacists and nurses who were going to administer vaccines to have a protocol with a physician, and had some other requirements such as liability insurance of at least $250,000 and basic cardiac life support, things like that. So far through the 19th of this month, we had registered 310 protocol agreements. We usually tell you how many licenses that we have active. As of the 19th, we had 47,399 among our 16 license types. Most of those, of course, are physicians. That represents about 35,000. And now I'm completely done.
That was short and sweet.
Hopefully the session is like that.
Well, we can dream. I don't see any lights on. Any questions? I guess I have one about the vaccine. I understand this is kind of the year for getting everybody registered and up to speed on the requirements. Do you have any thoughts on enforcement as time passes to make sure everybody's complying with it?
The board has discussed that with, of course, among its own membership, as well as with the Georgia Drugs and Narcotics Agency. And obviously, at some point, enforcement may become an issue. At this point, we found that there was pretty good implementation as far as pharmacies registering, and also we of course expected that we'd have to poke and prod a few of them to make sure that they were aware and what they needed to do and things like that. But it seems to be going pretty well so far. So at some point, we'll probably have to do the enforcement part, and we have been talking to GDNA about that, but right now it's not an issue yet.
Okay, thank you. Any other questions? Thank you for coming, and good luck.
Thanks.
Got Cherry Tucker next from Georgia Board for Physician Workforce. We won't, tell you that he only took 4 minutes or anything. We'll put any pressure on you.
Hey, mine will probably be just as short. Good morning, Mr. Chairman, and thank you for having us here today. I'm Sherry Tucker, the Executive Director of the Georgia Board for Physician Workforce. Many of you know about our board, but I'll go ahead and talk about the purpose. The purpose of the board is to address the healthcare workforce needs of Georgia communities through the support and development of medical education programs and to increase the number of physicians and healthcare practitioners practicing in underserved rural areas. Our fiscal year 16 appropriation totals $62.2 million. That is spread out with 6 budgetary programs, including administration, which is 1.06% of our budget. And for the amended fiscal year 16 governor's recommendations, there are no changes to our budget. So if anyone has any questions, I'll be glad to answer them.
No questions.
Okay.
You may have actually beat him. So
I know, really.
Congratulations.
I tried to spread it out, but
We're taking them off of 17. We'll be back.
Exactly.
okay. All right. Okay. Thank you.
Thank you for coming. Let's see. We may be a. Okay, our next presenter is not in the room yet, so take a minute to pause and get some coffee if you need to.
My question is what they anticipate for the 17 budget. Have they, I know this is not a hearing on the 17, but you know, there's no changes in 16. What do they have so we can be thinking about 17?
Be honest with you, I've not really gotten into the 17
haven't?
yet. I've just been looking at this. There's some changes, and I'm sure that they have some interest in I've talked to Sherry a little bit about some administrative help to make sure they can generate the reports in a timely fashion to get the information that the board needs to, you know, track everything and make sure we're on schedule. And there are a couple of changes that I did notice in there. There was the dental loan repayment program that we put in last year. That was taken out in the 17. So I think, you know, that'll be something we probably want to have a discussion about. And there's some other things in there too. But honestly, I've not really gotten into it that much yet.
The only reason I bring it up is because that's one of the Senate platforms is rural health care stabilization, and under that is workforce development.
Listen, I'm with you on that. I'll help beat the drum for you. You let me know.
Yeah, I think we're all taking that issue very seriously and have our, you know, have our ability to do some tweaking if we need to. So.
Yeah.
Good morning.
Good morning.
Okay, Chairman, we are ready.
All right. Thank you for coming. We'll get started.
Okay.
Good morning.
Good morning, everyone. It's my pleasure.
You would just get the mic a little closer so
Sure.
everybody can hear.
Is that better?
Yes.
Okay. It's my pleasure to present the governor's budget recommendation for the Department of Community Health for the amended fiscal year 2016. My co-pilot this morning is Stephanie Papps, our budget director. The agenda for the morning is to give a quick overview of where our 2016 budgeted funds are appropriated by program, and then we'll go into the cost drivers that are influencing our budget in this year and finish up with the itemized governor's budget recommendations. Okay, starting on slide 4, you saw this slide on Tuesday as well. This shows the distribution of funds across the programs in DCH, and as you can see, 97% of all state funds are budgeted in the Medicaid and Peach Care programs. Medicaid having to the age, blind, and disabled, and the low-income Medicaid. Okay. We have some highlights from state fiscal year 2016. General budget, there was a $2 million state funds cut in the administration program with the direction to reduce contract costs. $3.3 million in state funds was appropriated to the healthcare facility regulation program in order to allow for 8 additional nurse surveyors to come on board and to address a structural deficit that existed in the program at that time. We received $8.7 million to implement a rate increase for nursing facilities who had a change of ownership between January 2012 and June 2014. CMS has recently approved our state plan amendment for that, so we are moving forward with getting those rate increases distributed to the nursing facilities that qualify. We received $5.9 million to increase reimbursement rates for select OBGYN codes up to the 2014 Medicare fee schedule, and $17.2 million was added to increase reimbursement rates for select primary care codes. We have submitted the state plan amendment to CMS for this increase and are awaiting their approval. When it's received, we will reprocess claims back to July 1 to get the rate increases to the physicians. Okay, moving on to the cost drivers. On page 7, we've divided them up into 3 major areas. We have growth, which is driven by CMO capitation rates and enrollment growth in low-income Medicaid. Prescription drugs are certainly a big cost driver in our budget now, primarily due to high-cost specialty drugs such as hepatitis C. We saw this in fiscal year 15 as well, and it's continuing in FY16. And we have new drugs emerging for the treatment of cystic fibrosis, which we're also projecting to impact our budget in 2016. And finally, the Medicare Part D clawback payments have gone up as of January 2016. And this is driven by the high-cost specialty drugs, such as the hepatitis C drugs. So it's happening nationally, and Georgia is experiencing almost an 11% increase. We have a federal directives category, which includes 1095B reporting. This is reporting that's required pursuant to the Affordable Care Act. The Medicaid agency is required to mail certificates of coverage to Medicaid members. And you'll also see this in our admin budget for the state health benefit plan. That plan is required to do the same thing. We have increases in Medicare Part B premiums that went into effect January 2016. And as there was no cost of living adjustment for Social Security beneficiaries this year, the Medicaid agency is required to pick up that increase in premium, and those members are held harmless. And this increase is almost $20 per member per month, effective this month. And also, when we reached out to CMS to extend our contract with Hewlett-Packard for the management of our Medicaid information system, certain components of that contract were changed in terms of the federal matching rate. It went from the 75-25 enhanced matching rate to a 50-50 standard match rate. And that's resulting in over $2 million hit to departmental admin. Okay, next slide. Since growth is one of the primary drivers of our budget and certainly a big factor in our projections, we wanted to just show you what it's been the last couple of years and what we're projecting in FY16. You can see toward the left side of the chart the steep climb up when we move from 6-month eligibility determinations to 12-month for low-income Medicaid. And it has since pretty well stabilized, and we are projecting a similar enrollment trend in fiscal year 16 as we saw in fiscal year 15. Okay. And moving on to slide 10, these are the itemized governor's budget recommendations, and they begin on page 77 of the governor's amended budget report. Item number 1 is $32.5 million for benefit growth, and you will find benefit growth referenced in the age blind and disabled, low-income Medicaid, and Peach Care for Kids programs. In age blind and disabled, or ABD, and Peach Care, the projected growth is actually going down, and in low-income Medicaid, it is continuing to rise. So the three of them together are the $32.5 million. Item number 2 is the request for funding of $26.5 million for the hepatitis C drugs and cystic fibrosis drugs. The hepatitis C drugs have been the #1 drug in Georgia Medicaid in terms of cost for the last consecutive 18 months. The cystic fibrosis drugs are emerging, and we're starting to see more patients coming on with those medications in this fiscal year. Item number 3 is the Medicare Part D clawback payment. This is a monthly payment that the Medicaid agency remits to the federal government, and again, this increase is driven by high-cost specialty drugs, and we're projecting a $4 million impact to the budget, just over $4 million for Part D. And this went into effect in January, so this $4 million is reflecting a 6-month increase in the cost. Item number 4 is to provide state matching funds for private disproportionate share hospitals, both the federally deemed and non-deemed hospitals. The private hospitals are not allowed to submit an intergovernmental transfer, so typically in the amended budget, state funds are appropriated so that they can get the benefit of the funds for the federal funds for the DISH payment. Item number 5 is reflecting the increased cost to Georgia Medicaid for the increase in Medicare Part B premiums. This increase went into effect January 2016, and the per member per month that Medicaid is paying for these members went from $104.90 per month to $124.80 per month. Altogether, we have just under $91 million in state funds recommended for Medicaid benefits in the amended budget. Okay, the next slide, number 11, reflects operations items. All 3 of these items are reflected in Departmental Administration and Support Program. Item number 6 is the $1.8 million to cover projected costs of the 1095B reporting requirement. The department is working with Hewlett-Packard to fulfill this requirement to mail all these letters, and we're also required to electronically transmit a file to the IRS later this fiscal year. Thank you. Item number 7 reflects an increase for the reduced matching funds in the MMIS contract we have with Hewlett-Packard. Typically, IT projects and activities are funded at a 75-25 match rate, whereas the standard administrative match in Medicaid is 50-50. Upon review of the contract elements with CMS, they identified 4 pieces that were not eligible for 75-25 enhanced funding because they were not directly related to the MMIS. In other words, someone has to be touching the MMIS in order to qualify for that advanced enhanced funding. So that results in a $2.1 million impact to the department's budget. And item number 8 is analogous to the 1095B reporting requirement for Medicaid, and this is the state health benefit plan portion and DCH's portion to fund the overall SHBP 1095B reporting requirement. So the total recommendations for operations-related items is $3.9 million, bringing the governor's total recommendation for DCH to $94.9 million in state general funds. Okay, slide number 12 is turning to the state health benefit plan. There are 4 items included as yes items in the governor's budget recommendation. Item number 9 reflects the increase in Medicare Advantage plan premiums that the SHBP is paying, effective for plan year 2016. We saw some very aggressive savings in plan year 2015 that, the costs they rose in 2016. So we are still, the state health benefit plan is still saving compared to the Blue Cross Blue Shield Medicare Advantage rates, but we're not getting the same, aggressive discounts as we saw with United Healthcare in 2015. Item number 10 represents the organic changes in the state health benefit plan that aren't related to plan design or policy changes, but rather with the membership, service utilization, and medical trends. Item number 11 reflects a $5.5 million reduction in revenue to the plan due to the reduction in many of the SHBP members' employee premiums. All of the premiums went down between 15 and 16 with the exception of the high deductible health plan. Of course, people's premiums may have still gone up if they selected a more expensive plan in 2016, but overall, most people saw a discount between 15 and 16. And item number 12 reflects the delay in the increase in the non-certificated school service personnel employer contribution increase that was budgeted in House Bill 76. Rather than it being implemented July 1, 2015, it was implemented January 1, 2016. So this caption reflects the loss in revenue to the plan based on that delay. Okay, and the final slide is the operating statement for the state health benefit plan. We have audited financials for fiscal year 15 and projected for 16 through 18. One sec. And as you can see, we're projecting a surplus on line 15, the highlighted line. We're projecting an operational surplus in fiscal year 16 and 17 that is turning to a projected deficit in fiscal year 18. And this doesn't contemplate any additional plan design changes or premium increases or changes to the employer contribution other than the governor's recommended $100 per member per month increase in January 2017. So that's the close of the presentation. If anyone has questions, I'd be happy to answer them.
Chairman Underman.
Thank you. And I'm sorry, I have to go to another meeting. If you could just get me this answer and send it to my office, I would appreciate it. On the age blind and disabled, you have 53.1% of the total budget. Mm-hmm. Could you give me the number in 2016 of those high-end users? How many used that percentage of the budget for 16?
Okay.
Thank you.
Mm-hmm.
See. Representative Hawkins, did you have a question?
Under the cost drivers under growth, you have CMO rates. Could you speak to that a little bit?
Sure. Each year, the CMO rates are actuarially determined, and based on the most recent months of actual data, that goes into the development of the current year CMO rates. So we did see higher trends in the claims overall in fiscal year 15, which are influencing the development of fiscal year 16 rates. Some of the increase was funded in House Bill 76, the PCP and the OB rate increases. So we're not, even though it's part of the growth in the rates, we're not counting that as a cost driver because those funds are already available. So it's really about 2.8% overall increase in the CMO rates that is not part of the PCP and OB rate increases.
So that's actually driven by the request of the CMOs then, based on our utilization?
Yes, it's based on experience, and then, yes, we work with the CMOs on any, if they saw any particular experiences unique to them, or, we just go over what are all the considerations of the prior year, and what are the projected trends in pharmacy, for instance, and all that gets baked into the rates.
So when we started off with them, 2006, I remember the statements were, well, we are at risk, so we need to charge you this much. And actually, they're not at that much risk because following year they can come back and ask for increases. Is that right?
I would say that the rate development process is very strongly negotiated between DCH and the CMOs.
I trust that you do that. I trust that
yes.
you do that. Yes.
Yes.
You and Commissioner Reese. I have no doubt about that. Thank you.
You're welcome.
Yeah.
Let's see, Representative Quick, let me get your microphone on.
Chairman. Thank you, Mr. Chairman. Just a brief follow-up to Representative Hawkins' question. Are the CMO contracts due to expire at the end of FY 216?
Yes, ma'am, they were. We have requested extension of those contracts to CMS due to the protest period that we're experiencing with the CMO procurement.
And so that is a process. Is there a renegotiation, to his question, is there a renegotiation of the rates and the issue that we're discussing?
Well, the FY16 CMO rates have not been approved by CMS yet. So through today, we've been paying the CMOs at the FY15 rates. We have to wait for CMS approval before we can implement the new rate. So we're halfway through the year, and we haven't caught up to the FY16 rates yet. So when CMS approves that, we will reprocess the claims back to July 1. And right now, we are in the development process of the rates for 2017, so we don't actually have them yet.
Do you know when those will be available?
Linda, do you? I think possibly March. 2017 rates? March.
And my questions relate to the Indigent Care Trust Fund. First of all, I want to thank the department for posting the 2015 annual report in a timely fashion. That was helpful this year. But the Indigent Care Trust Fund documents are not posted. Is the FY 2015 ICTF financial revenue activities summary available?
Yes, ma'am, it should be. Those numbers are audited. So they are not on the website?
No, ma'am, and the FY 2015 audit reports are not as well.
Okay, we will take care of that.
We get those? And what is the internal document that would show us the activity in the Indigent Care Trust Fund for fiscal year 2016 to date?
I don't know that we have one. We could certainly, give you any information you need on what activity has transpired.
And so the requested state general fund appropriation for the Indigent Care Trust Fund for amended 2016 is what number? Is that 14?
Yes, 14.7 million.
The rest is the rest of the additional funds listed would be the federal component.
Yes, ma'am, as well as IGTs or other funds that the public hospitals remit in order to draw down the federal match.
Thank you, ma'am.
You're welcome.
Okay, we got a couple ahead of you. Let's see. Representative Taylor, I think you're next in the queue.
Thank you, Mr. Chairman. Several of my questions have been answered, and you directed it. Thank you. I had one additional one, and that had to do with the 1095B reporting. And again, I'd like to get the number of participants that I'm assuming this is mailing, it's the postage, it's the paper to actually get it done. How many people are we sending them to? I'd like to know that number.
Okay.
How many people are actually... and I realize some people may have only been on Medicaid 6 months or whatever, but we've changed it to this different type of eligibility, and I would like to do a little comparison.
Sure.
Thank you.
You're welcome.
Let's see. Representative C, I think you were next.
Yes, thank you.
I mean, sorry, Senator. Yeah.
Thank you, Mr. Chairman. Medicaid expansion provides health care to at least 650,000 Georgians, considering that's about 1 in 1,000 uninsured people that die from ailments that could otherwise be treated. The state refusal to expand Medicaid is actually more than murderers' rates. I'm real concerned because it's my understanding that just the expansion could create about 70,000 jobs right here in Georgia. And I do know that states like Arizona, Michigan, Ohio, Indiana have already expanded Medicaid. Louisiana, okay, that one too, just to name a few. But I'm real concerned. I am Senator C, and I do represent Clayton County, and Southern Regional is in my district, and I'm very concerned. Could you help me understand what the impact is, if that's something that we even track? And is this not the type of opportunity that Georgia should use to save lives and grow the economy?
Well, I would say that echo the commissioner's comments from Tuesday that now, the department is operating within the confines of current law and the funds that we have budgeted to operate the Medicaid program. We certainly, partner with people to provide information to help, policymakers make decisions. But that's all I can say.
That's all you got.
Yeah.
Go ahead.
When CMOs, the contracts are signed, cut rates to providers, do they notify you of that?
I am not sure. I will need to follow up on that for you.
Well, let me tell you, from the dental standpoint, 2008, they cut rates in the Atlanta region for the most used procedures on children by up to 40%. And I didn't see a decreased cost to the state. So that's just a mechanism that concerns me, and we do see those from time to time, especially when we see rates going up and their commitment to the providers going down. Thanks.
We'll follow up on that.
One last question. Can we see these contracts after they're signed?
The contracts between the
With the
CMOs and
CMOs?
providers? Linda, do you know?
We can't.
Or we don't, but
I'm sorry, what? We don't see the contracts between the CMOs. No, I'm talking about the CMOs and the state. Yeah, we can see those?
sure,
Okay, great.
we'll
Thanks.
send those.
Representative Stevens, I think your light was on.
Thank you, Mr. Chairman. I'm following that same line. That was my first question, is the CMO rates seem to be going up while pharmacy rates, dental rates, and every other provider rate seems to be going down consistently every year, probably after the contract has been signed. But along the lines of, again, on a CMO, we used to get huge drug rebates. Is that factored into the base now, or is there any drug rebates coming back to the state?
Yes, there are.
Then the question becomes, if a CMO stops covering a drug, that rebate then is a double whammy to the state, because then we don't get the rebate on that drug. Is that true?
Linda, I'm throwing
Let's
out
just-
a lifeline.
When you're talking about rebates to the CMOs, they work a little bit differently.
Let me interrupt 1 second. Can everybody hear her, or does she need to go up to the podium? Okay. And just for the record, this is Linda White, the Medicaid Director. Welcome.
All right. Good morning, everyone. To address the question specifically about the CMO rebates, they function a little differently. The CMOs are, just like the state, free to contract for rebates themselves. Any rebates that they contract with in terms of developing their preferred drug list remain with them. The rebates that we receive as the state are the CMO mandated rebates that Liz was referring to. So the rebates that come back to us are those that are mandated by law by CMS. So the impact of a change in their preferred drug list is kind of complicated to get a handle on, because we will still receive the CMS rebates regardless of what the status is on the CMO preferred drug list. So what you would see then is a change. Perhaps one drug might go down in terms of CMS rebates, but another drug likely will come up because it will be replacing the original drug on the preferred drug list. So does that help?
It does, and I guess there's never a scenario where a CMO might discontinue a drug that the state were then getting a rebate on.
We get rebates on every drug, regardless of the status on the preferred drug list of either the state or the CMO. So there's always two parts to rebates. There's the CMS federally mandated part. We will always get that piece. We get it for both fee-for-service drugs and for the CMO drugs. Then you have the supplemental rebates. The CMOs contract for their own. The state contracts for their own. And we do have different preferred drug lists than some of the managed care organizations, probably than all three in certain categories. But what they do on their preferred drug list does not impact our supplemental rebates.
That was my question.
Was that the question? Okay.
It is. Thank you.
I think it may be helpful if y'all could provide us with some information on the rebate process, maybe the amount of funds involved for each category that you were just describing. I think that would be helpful. Let's see. Representative Taylor, you have another question?
Thank you. Since we've started talking about prescription drugs, I do have some questions. The commissioner mentioned about having some audits. I did not see a line item in here, any increased funds to pay for audits. And I kind of want to get into that, because part of this problem with rebates, my understanding is they don't come back at the point of sale. It's months and months, 6 months later, 8 months before you ever get the rebates. Is that correct? It's very difficult to track it per script to know where or if you're actually getting your rebate.
Are you concerned specifically about the rebates coming back to the state?
Yes.
Okay.
That's the one I'm...
Do you want me to take a few minutes to talk about the rebate process now? Do you have... I'll try to keep it
I think we can take a few minutes.
Okay, I'll try to keep it
Okay.
quick. Rebates are billed quarterly. They can't be billed until after the close of the quarter. So, for example, and there's a CMS mandated timeline for when they have to be billed. So if first quarter ends, CMS has a little over a month to get reports from manufacturers that speak to their best price and the average manufacturer's price, and calculate what those mandated rebates are going to be. After that is published by CMS, we have a vendor who takes that file, calculates what the rebates are, and there are other things that go into the calculation, not just the mandated percentage that's in federal law, but also some increases due to inflation. So they calculate those rebates, they bill the rebates, and then the manufacturers have a specific amount of time. They have 30 days to get that calculation done into the manufacturers. The manufacturers then have 30 days to pay. So you're right. If you billed for a drug at retail in January, you probably won't see a payment until June. But that is partly because of the process, and it's actually a very well-oiled process. It functions very well. At the end of that quarter, we receive reports all the time that detail what's been billed to the manufacturer and how much we have received. And the funds actually come to lockboxes at the state, not to the rebate manufacturer, or not to the rebate vendor, but to the state. So there's not an opportunity for anything really to go amiss there. So I don't know if that answers your question or helps, but
It does, but
Okay.
I don't know if he was talking specifically about the CMOs, but the state health plan also. I didn't see anything
Okay.
in here
Right.
for, my guess is if you audit the Medicaid, you're not going to find nearly as many errors as you will in the state health plan.
And state health benefit, you're right, that's a completely different rebate
Totally
process.
different.
Is that something you also want information on when
Yes.
Okay.
Yes.
So we'll get state health benefit plan to provide something as well.
If we have additional audits, I just didn't see it in here where it would be costly and where it would be. Thank you.
All right. Mr. Chairman, you have a question?
Thank you. In your presentation, there were two items on the increased reimbursement. One was the $5.9 million for select OBGYN codes, and then the $17 million for select primary codes. Help me understand that. One we're currently paying, right? And the
Yes,
other
sir.
we're still waiting on CMS approval?
Yes, sir, for the PCP rate increases. So we're waiting on the increases that were funded with the $17.2 million.
Right, so we funded that to take effect July 1, and now we're in January, and we still haven't paid it because we haven't gotten approval from CMS to do that, right?
That's correct.
Does it normally take that long to get the approval from CMS, or when would you guess we may see some benefit to our providers, or what?
Okay, right. Linda brought up a good point. The CMOs are already distributing the higher rates to their enrolled providers. We have not made the switch on the fee-for-service side because the rates haven't been approved. And when they are, we will reprocess claims back to July 1 so that providers can realize that increase for the full fiscal year. My experience with CMS is certainly more limited than Linda's, but there does seem to be incredible variety in the response time for state plan amendment requests. They do have 90 days to ask any questions, and when they do ask questions, that stops the clock. So there's this, the 90 days and then the stopping and starting of the clock, and then it just, I think, depends on how many other plan amendments and waivers they're evaluating. Because my understanding is they only do one at a time. Is that right? Or at least one area of CMS does one at a time.
So the increased fee is being paid for everything except fee-for-service, is that right?
Yes.
What happens if they don't approve that and the CMOs are already paying it? Is there any clawback on that?
I can't answer that right now. I'd have to
Thank you.
get an answer for you.
And what about the OB?
They're together.
They're
Okay.
in one spot.
So that still hasn't happened yet from fee-for-service, but it is happening in the CMOs.
That's my understanding.
Okay.
Although this
Yes.
has taken longer than we have anticipated.
Us too. Senator C.
Thank you, Mr. Chairman. Just to follow up on that information that we're going to get on the rebates, if you don't mind, I'm assuming that the vendors are the entity that's handling that process. It's at a cost, is it not? Yeah. And so so with that report, if you don't mind including what that cost is, so we can actually see what we are actually getting.
Sure. For the Medicaid side, we have a separate standalone contract, so that's easy information to get.
Okay.
It may be a little more difficult for SHBP. Certainly can't speak for them, but it may be just a heads up bundled into that Express Scripts contract. But we'll do the best we can.
Thank you.
Representative Quick.
Thank you, Mr. Chairman. But back to my chairman's question about this approval process, where are we now in terms of whose court is the ball in? Is it in ours, or is this delay now attributable to the federal government?
The ball is not in our court. It's with CMS.
And is there anything at all that can be done to accelerate that so that we've got some certainty in our budgeting process?
Well, we've certainly been asking them regularly for where they are. Is there anything else you need? I mean, the questions that they've already asked have been answered. So, Linda, do you have anything to add?
No, unfortunately. I'm sorry.
Thank you, ma'am.
We may need to call our federal legislators. What
Yes,
do you think? All right, Representative Gardner.
In terms of CMS approval of different kinds of waivers, which I am, that's not really a waiver, is it?
No, this is a state plan amendment.
State plan amendment.
Mm-hmm.
I know there are attempts on the part, at least of a couple of the safety net hospitals, to create a waiver that might allow for more coverage for people who are adults in our system who are poor, probably people with mental illness. And I wondered how the department, what's the department's position on those waivers in relationship to getting approval from CMS? Can you talk about that at all?
A little bit. Okay. All right, and I presume you're asking about the proposal from last year that Grady and Memorial put forth?
Yes, ma'am.
Okay. We have spoken with Grady a couple of times in the interim. They are coming back to us with additional information and proposals, and I believe I have a conference call scheduled with them later in the month to see where they are. So I don't know that we have a specific position. If they come up with something that is acceptable to all the parties, we're certainly not opposed to pursuing it, but at this point in time, I don't think we have a specific position.
So I guess the question is it a political decision, or is it based on the possibility of getting an additional 50,000 people the help they need?
I think
is it based on the numbers and the impact on the state budget?
I am certain that when we receive something back and understand it, I'm sure that the commissioner will be discussing it at other levels of government.
Thank you.
Mm-hmm.
That was a very good answer. I think the governor will be proud of you today. Let's see. The only other question I have is if you could get me some information on the cystic fibrosis for fee-for-service, the requirements
Sure.
for that, and as well as if you have the CMO's requirements for getting that approved, is it different between the different organizations? And if it is, how different? I'd like to get that information. You would request it from them.
So the specific prior authorization requirements?
Right.
Okay.
And which drugs and how many they use, that sort of thing. Okay. Any other questions? I don't see any. All right, I'll let you do that.
Just to remind the members on our subcommittee, we'll be back at 2 o'clock in here for the public health portion of the budget.
All right, I want to thank everybody for coming. Appreciate your all's
Thank you.
presentation, and we are adjourned.